First of all, what is the availability of emicizumab now? Do you have it in your pharmacy, in your mail pharmacy?
At first, it was only certain pharmacies, and we were one of the first ones to get it. So I don't know how available it is now. I believe it's starting to be rolled out.
I
and
think you
it's
can
fairly
buy it pretty
common.
much anywhere. It's
So if it's available, if it's commonly available, there's stock here. How is this changing the entire landscape of hemophilia therapy?
Oh, it's radical from every person, pharmacist, everybody. It's changing everything. I mean, so you're talking about a drug that you don't typically have to monitor its effect. It changes the route, so you don't need as many nurses going out to infuse the patient. They still have to go out for bleeding treatments, but you're talking about a medication that's going to significantly reduce bleeding, and so it definitely is going to change things. It is, like you mentioned, it's not available at every specialty pharmacy, and they've actually put some restrictions and make sure that who they're working with are reputable, have experience in this. So some of the mom and pop ones may not be around, which isn't always a big deal to us. You know, it's important for patient access. We're not worried about that, but it's going to change the way we take care of patients. You know, if a patient has an inhibitor, they have a choice to treat it or to put them on emicizumab, and we're looking at whether you can do both at the same time off-label, but it just opens up another set of medications that patients have, and so.
And we have 5 patients currently on it, and it's been a game changer.
Really?
For those patients with inhibitors.
Yeah, that's not an
As
exaggeration.
far as cost savings as well.
I was going to
Yes.
ask about that.
Dramatically cheaper. Not only the medicine is cheaper, but the nursing. It's subcutaneous. You don't need as much nursing care or instruction. So that's a big cost savings as well.
I mean, it occurs to me that when you look at cost, we come to this whole silo issue, you know. Well, I don't have to pay for this, but somewhere in the global
We're all
healthcare
paying for
delivery
it.
system, we're all paying for something. If you were to lump the meatball, if you will, of healthcare per year for somebody with hemophilia without emicizumab, what would that be? What would that number be?
Yeah, I mean, you might have a better idea, so.
Well, it depends on the patient's age because the factor is dosed per kilogram.
Okay.
Some patients get $100,000 with the factor every month.
Every
so that's
month?
the
Yes.
medication alone.
That's $1.2 million.
Yeah.
Yeah.
I did that in my head.
Yeah.
Hemlibra is maybe $2,000 a month. But I only have one patient on it, and he's a child. So he only gets a very small amount.
He's got a very
It's about
small vial,
$2,000.
Yeah, I think it's drastically different between an adult and a pediatric
Yeah, of course,
patient.
yeah.
I think I just did an analysis of a patient who is coming into our center who is not very compliant or adherent, and they're potentially considering switching him to emicizumab instead of his normal factor VIII therapy. You know, he was at $30,000 to $35,000 if he was treating appropriately. And if we treated him with emicizumab, it's going to be about $60,000.
Right.
So it's different.
It is, and if you take everything, I mean, if there's
Yeah.
fewer bleeds,
Yeah.
fewer ER visits,
Yep.
fewer surgeries,
Yep.
if you can control the bleeding.
Sure.
So you were talking 7 figures. Now we're talking 6 figures, maybe high 5 figures. There's a difference.
Yeah, I mean, like you mentioned, it varies. In a young child, they may spend somewhere between $150,000 to $400,000, depending on their weight and their factor consumption, for standard factor VIII and IX products. And some of the extended half-life products are more expensive, of course. And so it's going to be fairly close. It's somewhere in the $300,000 range, you know, depending on per year. And so, but when you look at inhibitor patients, like we were talking about, the costs are just dramatic. Like she mentioned, we had patients that were spending $3-4 million a year trying to get rid of their inhibitor, and that's one teenage patient. And that patient that I was referring to, we weren't able to get rid of the inhibitor, so we probably spent $10-15 million, and we weren't successful.
That's national debt kind of number.
Yeah, and so that's not sustainable, and we're seeing these in the community, and there's pressure on those patients. It's not their fault that they have this, right? And so it's a shared cost, and so for the inhibitor patients, there's no doubt that there's a cost savings. It's not even a contest. It's more of the non-inhibitor patients. It's going to be more of a discussion.
But it sounds like there's a cost saving there too, in all likelihood.
Yeah, there's definitely that. Yeah, a hospital cost savings.
For
exactly.
the inhibitor patients, get rid of the inhibitors is an issue.
Yeah.
Right? We don't care you're there anymore.
Yeah.
We'll give you something that chunks you away.
Sure.
We like this. Now, you mentioned trials. Right? There's the Haven 1
Yep.
and the Haven 2. What are those trials?
So the Haven 1 trials were looking at this use in adults. So as you know, in clinical trials, you always start with 18 and older patients. And so they looked at patients with inhibitors, 18 and older, and they wanted to look at the ability to reduce the bleeding rate. And there was a dramatic bleed. It was in the upper 80% reduction of bleeds compared to not doing anything. And the great thing about these studies, the Haven 1, 2, and 3, they had these non-interventional arms. And so the biggest criticism about studies is you're measuring it different than I measure it at home. So when I count bleeds at home, you count it different on a trial than I measure it when I'm at home by myself. And so they took patients as a lead-in, measured their bleeding events the same way in the trial. And what they saw in Haven 2 and 3 is that even when people were on factor VIII prophylaxis, there was a reduction in bleeds when they switched to Emicizumab. So, it wasn't a direct comparison, but it was a, comparison afterwards. And we had, the median annualized bleeding rates for some of these kids were less than 1. And so these kids were having 1, maybe 0 to 1 bleeding events per year that were required treatment.
That's dramatic, right?
Just dramatic.
And was it a powerful enough study to take these results and expand them and apply them?
Well, I think it certainly is powerful. Our center still is kind of philosophizing as to how they might use it in some of their kind of non-inhibitor patients. And it's a difficult question. How do you know if they're bleeding or not? Or do you just wait and see and call me tomorrow and see what it looks like, or put ice and compression and elevation and do those kind of
non-pharmacological... Don't take 2 aspirin and call me in the morning.
Exactly.
Yeah. So bleeding events are more of a discussion. Before, if we told them if your joint felt warm or tingly, go ahead and treat it. We're never going to say you did something wrong, right? Now we're saying, why don't you wait a little bit, see what happens. If it progresses, then treat it. Maybe it's your arthritis. It might not be a bleeding event. And so that's the challenge in adult patients, certainly, is it's very difficult to discern arthritis between an acute joint bleed. And so now we're having discussions about individual bleeding events.